MRI in GU malignancy, case-based approach. It will be presented by Dr. Rasha Salah from Ain Shams University. Please, Dr. Rasha.
Professors, good morning, dear professors and colleagues. It's my pleasure to be here with you. Today we will introduce the new era of PET imaging, which is PET MRI. This is my acknowledgement. We are going to minimize this great issue into two major items, talking about the PSMA PET MRI for the prostate cancer and also FDG PET MRI for renal masses. Let's start with the prostate cancer PSMA. What about PET MRI for the prostate? We perform the state-of-the-art multiparametric MRI with all its available tools for characterizing prostatic cancer. And also we apply the additional PET imaging, which is of great value in evaluating nodal and distant metastasis. So this imaging modality combines these two major high-end techniques for local and distant staging. Multiple studies encompass the added value of PET MRI, especially in staging for high-risk patient group and also high and intermediate risk group, because it is of high significance in evaluating distant metastatic disease. Also, PET MRI is very valuable in local staging, especially in biochemical recurrence. This is a recent study which studied more than 2,000 patients and underwent a meta-analysis, and this showed that PET MRI have more sensitivity in detection of the primary tumor compared to multiparametric MRI alone, with a sensitivity of 94.9%. Also, at restaging, PET MRI is more sensitive and more specific compared to the conventional choline PET imaging. What is the difference between PET-CT and PET MRI? There is a good agreement between both modalities. However, PET MRI is superior in detecting local prostatic disease due to the superiority of MRI imaging in evaluating prostatic masses compared to CT alone. Also, MRI is very crucial in evaluating nodal metastasis, because the longer acquisition encountered in the PET imaging on MRI's machine allow detection of smaller lymph nodes compared to the PET-CT. Also, MRI have an added value in evaluating bone marrow lesions, which is more sensitive compared to the CT alone, which can miss early marrow involvement. So PET imaging, as we all know, we inject the patient with the radioactive material. The patient is allowed to wait for about 60 minutes, then imaging start on the machine. PET MRI protocol include whole body imaging for evaluation of the bone, lymph nodes, also lung evaluation, and to evaluate the rest of the body. We also perform local multiparametric MRI for proper evaluation of the prostatic lesion. Let's talk about its value in every step in prostate cancer. First, for staging. This was patient with pathologically proven prostate cancer, grade group 3. This is a mass located over here, and we can see that there is an extraprostatic extension located with the corresponding restricted diffusion on the diffusion weighted image. Also, there is infiltration of both seminal vesicles, and it is very nicely demonstrated on the MRI. And this is the DCE image showing hyperperfusion of the mass. So we performed local staging by the multiparametric MRI, and the fused PET image confirmed the infiltration of the seminal vesicle, as we can see here that there is a true uptake at the infiltrated seminal vesicles. What about these small pelvic lymph nodes? Are they metastatic, or they are just an incidental small lymph nodes? Actually, on the conventional MRI alone, this is a difficult question to be answered, because they are small and more or less they appear to be homogeneous. So when we performed the fused PET MRI, we noticed that there is increased uptake, and this upstage these lymph nodes into true metastatic lymph nodes. and another suspicious metastatic lymph node located at the right pelvis, and it appeared to be morphologically suspicious on MRI because it is globular, and also it shows increased PSMA uptake over here. What about this small lymph node located at the left supraclavicular region? It is very small, and it is very difficult to characterize. Is it metastatic or it is just an incidental lymph node? But when performing the fused PET imaging, it shows uptake as well, and this is the coronal fused MET imaging showing increased uptake at this supraclavicular lymph node, and this upstage this patient into T3B due to the seminal vesicle invasion, N1 due to metastatic pelvic lymph nodes, and M1A due to the presence of this left supraclavicular lymph node. Another case scenario with prostate cancer and the suspected metastatic lymph nodes on the conventional MRI. This is the conventional multiparametric MRI showing a huge infiltrative mass lesion located at the central gland anteriorly. And this is the PET imaging confirming the increased uptake on the PET image by the PSMA tracer, and this is the fused images showing increased uptake at the mass noted with the low ADC value and also hyperperfusion on the perfusion image. And this confirmed the local prostatic mass and its true extensions. What about the lymph nodes? This is a large lymph node located at the left hemipelvis. However, when we look at the PET imaging, there is no uptake at all at this lymph node. And this is the fused image showing a completely negative lymph node uptake, although the lymph node is relatively large. Also, there are multiple left para-aortic lymph nodes, and they are morphologically suspicious for being metastatic lymph nodes. However, on the fused image, they are completely negative. And another mediastinal lymph nodes, which appear also to be equivocal on the conventional image to be metastatic lymph nodes, but they are completely negative. And this is completely different from the primary prostatic tumor. This is the map imaging for the patient with no distant avid lymph nodes uptake, and we suggested that these lymph nodes are due to other pathology, either sarcoidosis or just inflammatory, chronic inflammatory status, and pathologists are still bending for characterizing these lymph nodes. For evaluating treatment response, it is very valuable to use the PET MRI. Let's see this patient with previous HIFU, which is a local treatment for the prostate. This is the T2 showing that the treated area appear to be completely cystic. And this is the diffusion with the ADC with no restricted diffusion, denoting that this is a well-treated prostatic lesion. Also negative uptake on the contrast image and also on the perfusion. After fusing this conventional imaging with the PET MRI, it appeared to be also completely negative for PET. So this patient is having a very good local response for the prostatic tumor. But why the PSA is rising in this patient? Let's see this small pelvic lymph node, and again it is an equivocal lymph node on conventional image, but it appeared to be significantly avid on the fused PET MRI. Another left pelvic lymph node appeared to be larger and more heterogeneous on the conventional image with also increased uptake. And these are the site of the increased uptake on the MEP imaging, locating that there are metastatic lymph nodes with well-treated primary prostatic tumor and no other distant metastasis. So this answered the questions why this patient have a rising PSA. Let's see the biochemical recurrence, which is a challenging question to be answered by the radiologist. This patient have a previous radical prostatectomy and received radiotherapy. Let's see this conventional T2 weighted image. We notice that there is a small nodule located at the bladder neck posteriorly, and it appeared to be slightly hyperintense compared to the rest of the fibrosis located around the bladder neck. And by this T2 image, this is suspicious for local recurrence around the bladder neck, which is a common site for local recurrence. And this is the sagittal image. Let's see the perfusion. This nodule appeared to be hyperperfused compared to the rest of the fibrosis around the bladder neck. And unfortunately, this nodule was completely masked by the PET image due to the tracer excretion into the urine. So if this patient performed just PET-CT, this small recurrence at the bladder neck can be completely missed and the imaging will be completely negative. But we are lucky to have this patient performing this PET MRI study, and we confirmed the presence of local recurrence. Let's go for renal cancer. PET imaging have relatively low sensitivity and specificity for renal masses, because the uptake in the excretion of the FDG tracer into the urine can mask small renal masses uptake on the PET image. But it has an excellent role in extrarenal evaluation for extrarenal disease regarding venous infiltration by the tumor or nodal metastasis. So regarding the evaluation of renal masses by the PET imaging, still the conventional imaging, either CT or MRI, plays a cornerstone for its diagnosis and staging, but PET is valuable in evaluating nodal and distant metastases. Also, PET imaging have a role in differentiating the degree of the renal tumor. Let's see this patient. This patient was with accidentally discovered left renal lesion. There is a huge exophytic left renal mass with heterogeneous appearance and hemorrhagic component and some papillary projections located over here. This is the diffusion confirming the presence of the papillary solidish component, and on the PET fused images, these papillary components are the only components that show uptake. And this is the fused image. We can see that there is a discrepancy between uptake. But what about these lymph nodes? They appear to be completely negative on PET, and this confirmed that these are not metastatic lymph nodes. And on surgical evaluation of these lymph nodes and the mass, it was proved to be papillary renal cell carcinoma with negative nodal metastasis. Another example for a more suspicious renal mass, this is a heterogeneous huge mass, and this is the perfusion image with heterogeneous enhancement. Also, there is heterogeneous FDG uptake noted at this patient. Also, we can evaluate the pulmonary metastasis by this marvelous technique, which is the ZDTE. Unfortunately, we noticed that there is a small lymph node which can be indeterminate on the conventional image, and it was proved to be, I will sum up, to be true metastatic lymph nodes. And unfortunately, there is also metastatic pulmonary nodule, in spite that there are some hypotheses that MRI is having the limitations in detecting pulmonary metastasis. But this amazing sequence, which is known as the ZTE, showing the pulmonary metastasis exactly as we can see on the CT images. To sum up, PET MRI avoids radiation exposure included in the CT. It also allows local staging properly, and it have an additive role in evaluating nodal and distant metastases. So it is very valuable in evaluation of local recurrence and discriminating post-treatment changes from recurrent tumors. Thank you.
Thank you, Dr. Rasha. The next session will be presented by Dr. Ain Shams from Ain Shams University under title of Focal